Hello everyone, my name is Dr. Evan Katz of Katz Chiropractic and Rehabilitation Clinic, where I practice with my wife, Dr. Shauna Katz in Boulder, Colorado. We do have a digital motion x-ray, which I'm going to discuss what that is, but we also were some of the authors that published the largest study determining injured versus non-injured necks and what some of those parameters were to determine what is an injury and what isn't. Today what I want to do is go over what some of those findings are, what some of those findings mean, and how we were able to treat those in our office and even some other treatment options. So when you're watching this video, please leave comments below, questions, reach out to us, and I want to discuss why if you had a DMX with us, what some of these findings may mean, or if you're thinking about a DMX, why you should come to our office. And we have patients that fly in all the time to get a digital motion x-ray with us as opposed to potentially some other centers out there, and I'm going to explain why that is. So first, let's just go over what is digital motion x-ray. It is a fluoroscopic examination of the spine, also known as VF or DMX, and it allows for continuous and minute examination and movement within the cervical spine, including abnormalities of intervertebral motion associated with ligamentous instability. The DMX that we used is 30 images a second. Now, some VF do not do 30 images a second, and those are ones you do not want to have your spine measured with. So in our office, we have about 20 years of experience with digital motion x-ray. There's a lot of people that are just getting them now, and we're proud of that because a lot of it had to do with some of the research that we published on this and the importance for our patients. But what we found is that also, I've testified using DMX and DMX technology and the findings in court over 20 times in the state of Colorado. Where my wife and I, when we take the images, we're also published docs. In our office, I was also the recipient of Chiropractor of the Year through Chiropractic Biophysics, the most researched and published chiropractic technique. I was also named Researcher of the Year, and just in 2021, thanks to all the Colorado chiropractors through the Colorado Chiropractic Association, I was named Innovator of the Year. Here's a little newsletter that we did way back in 2005 that my wife did, showing that even back in 2005, we were getting publications and write-ups on this technology. This is how long we've had it. We just did the largest publication ever by our office and some other docs. Here's the title of it. It's the Diagnostic Accuracy of Video Fluoroscopy for Symptomatic Cervical Spine Injury Following Whiplash Trauma. So what does this paper show? Why is this important? Well, it does show injury. It shows specific injuries that have significant short and long-term health consequences and disability. Now, a lot of times we have patients that get DMXs, they get sent in, other doctors may do them, but they're not really understanding what these pathologies mean. We want to know what these pathologies mean. We want to educate our patients and the ones that get DMXs in our office of what these injuries mean. And it determines the likelihood of an injury compared to an asymptomatic individual. So patients that were in crashes, and we do it, how do you know they were hurt? We can now determine the likelihood of injury compared to the asymptomatic population. And it's looking at biomechanical and structural pathologies in all ranges of motion, not just end ranges. MRI is great, CT is great, X-ray is great, flexion extension images are great, but they're just a picture in time. It's like saying, hey, my golf swing is terrible, and then you only have a picture to show your golf swing, and you're trying to analyze that one movement as opposed to going all the way through. We can move all the way through and see if there's biomechanical abnormalities, not just here, not just here, not just here, but all the way through. Which most people do hurt when they move, right? So let's look at one of the pathologies that when you get a DMX with us that we mark and measure and compare to normals. First one is loss of the cervical curve. As you can see here on your reading left, that's what a normal neck looks like. Here's a static view from our DMX where we write they have a cervical kyphosis and what the percentage of loss is. We now have objective information. Now, big deal, what does that mean? So there's a lot of literature, and I just picked a couple out here. We could always go into this in more detail. In patients with a kyphotic deformity, necks going the wrong way, the spinal cord shifts to the anterior portion of the spinal canal and abuts the posterior aspect of the vertebral bodies at the apex of the deformity. With the progression of kyphosis, the mechanical stress applied to the anterior aspect of the spinal cord eventually increases. In addition, dynamic forces caused by segmental instability, we can determine that on the DMX, which is often seen at the level of kyphosis, particularly in cervical flexion movement, contribute to compromised cord function. That was published in Journal of Neurosurgery Spine. Now, you have a loss of curve, big deal. It is a big deal. It can, according to this paper here and many, many others, it can literally irritate your spinal cord. This is something we want to identify and something we can fix. Here's a quick video I had made that shows a normal neck curve moving compared to a curve that isn't moving well. The green line represents the spinal cord, the blue is the discs, and as you can see, when we go through it, you'll see how with a normal curve, there's space where the curve is, and then when there's an abnormal curve, you'll see how there's tension on the ligaments, the discs, and that spinal cord ends up getting bumped. That can happen, and we want to know about that with the digital motion x-ray. Loss of curve and decreased blood flow to the brain. This is a paper that we also published as well in the Journal of Brain Circulation with some other authors. What we found was that an abnormal cervical curve, if we identify it on your DMX and imaging and we measure it, that it can also be linked to abnormal blood flow to your brain. Not a good thing. Here are some pictures from our study that on the top left is the vessels on the inside of the brain. On the right, when it's in red, we do what's called pixel intensity. Below on the bottom left, you'll see this is the same patient above, but they now have a normal neck curve. We put their neck into a normal lordosis, and what we found was that that increased blood flow up to 225%, or really an abnormal neck curve decreased blood flow. And in our office, we don't just say, you have a loss of curve. We don't just say, that's the way it could be. We implement a technique that can fix this curve. And here's a quick picture where we just dramatically improved the patient's neck, and we have lots of pre and post. We do a pre and post on all of our patients to show if there's an improvement. So now we're going to get into mid-cervical instability, right? That's from, let's say, C3 to C7, even C2 to C7, what we're looking at. Here's a video of our DMX that you can see when we start to move it. So as you can see, we're seeing how that moves and how there's a slippage. Now, how do we measure that? When you come to our office, we use this technology to measure the images, compare it to norms, and the red line shows that there's an abnormality. We can see when I'm looking at the DMX, when to pause it and to measure it, to look for some of these instabilities that could be a problem. We also give the numbers of what the established normal should be, and if you are over that established normal, leading to instability. Now, why is that a problem? Well, let's take a look at what some of the research is. We want to understand what this means to you, right? If we do a DMX and we see these problems, you want to know how this can affect you. What does the research show? How can this be affecting you from a physiological perspective? Dynamic elements, meaning as you're moving, can magnify the static component of canal deformation by ligamentous and osseous pathology, meaning the area of your spinal cord can start to decrease the diameter. And that these motion-related factors, not only do they reduce space, but they can also compromise capillaries and microvasculature that maintain a steady supply of oxygen and nutrients to the spinal cord. That was published in Journal of Neurosurgery in 2015. So if we see instability, not only is it a problem and it can lead to long-term irritation and pain and degeneration, there's all studies to suggest and support that, but it also can irritate your spinal cord. This is why we want to fix this. Now, what about mid-cervical and long-term? Okay, we diagnosed with instability. Here's a study that shows that essentially it means that radiculopathy, meaning the nerve root gets compressed and irritated, is a manifestation of spinal instability, meaning if you're diagnosed with spinal instability and you leave it, it will most likely down the road lead to radiculopathy. That was published in Journal of Craniovertebral Junction of the Spine in 2018. Now, mid-cervical and crashes. We're going to talk a little bit about car crashes because we see a lot of patients in crashes with this technology. In this paper, looked at 692 records were collected, 432 were removed, where we ended up keeping 261 radiographs of these patients. What we found in this study was that the study suggests that the specific forces involved in a crash lead to particular patterns of subfailure instability in female subjects. We found that in this study that car crashes and looking at different vectors led to mid-cervical instability. This was published in Journal of Pain Physician in 2007, and I was one of the authors of this paper as well. Now, mid-cervical spondy correction, when that area is slipped, can we fix that? We want to know if it's unstable and how can we fix that? Well, here's a paper that I was the author of as well, published in Journal of Musculoskeletal Radiology, Improvements in Cervical Spinal Canal Diameter and Neck Disability following correction of cervical lordosis and cervical spondylolisthesis using chiropractic biophysics. Here are some pre and post pictures. On the left, complete abnormal curve, that mid-cervical slippage and instability even on a neutral view, with canal narrowing. On the right, this is how we were able to fix this person, and we did multiple of these, getting it published in a journal. Here's another picture. As you can see, the red line is now more closer to the green line and more aligned with the one itself, minimizing compression of the spinal canal or minimizing the canal diameter. So how do we know that this is abnormal? We do a DMX and we say, this mid-cervical instability is a problem. Like, well, how do you know that's not part of the asymptomatic group? We hear patients all the time like, well, my doc says they think that's normal. It doesn't matter what they think. What matters is what is the actual answer to this. And what we know is we know it's abnormal. And here's how we know. The paper that we did, our study, shows us, we compared it. It's the largest study that compares injured and asymptomatic people looking through all these parameters. And here's what we found. When we look at here, it says table 3, we looked at C2 to C7 translation, as well as intervertebral angulation. There's some stuff in here that I'm not going to go over just due to time, where we looked at mid-phase range of motion as well, which is a problem. But what we found is that if you look at this C5 and C6, we found 19% of the symptomatic individuals had instability and only 2% of the asymptomatic. We found at C7 intervertebral angulation, 25% of the symptomatic population had it at one level and only 7% on the other. So now we're going to talk a little bit about facet injury. Facets are where one bone meets the other in our spine, and they've been very well documented to be pain generators. So if you get a DMX from us or someone says you have a facet injury, we want to know what facet is damaged and what is it actually doing, because there's multiple reasons that it could be hurt. So one, capsular ligament laxity can occur instantaneously as a single macro trauma, such as whiplash injury or other types of trauma. And it can lead to ligament laxity, excessive motion of the facet joints, which then can relate in instability. The capsular ligaments are the main stabilizing structures of facet joints in the cervical spine and have been implicated a major source of chronic pain. We want to know if you have this. And you could also see how it can affect your spine. This was published in Open Orthopedic Journal back in 2014. So what are facet injuries? Well, there's patients I know they get facet injections, it numbs it, they're like, my pain went away. The question is, we still don't know what it is. Is it because it's lax? Is it because, here's a picture here, is it bleeding? Is the cartilage torn? Are there small little fractures? Or is the capsule torn? Sometimes we don't know. All of those can lead to facet pain. And if you numb it, it can say it went away. It still doesn't tell us what that pathology is. We want to find out what that is. And if you look, many of you watching may see that they have this pain pattern. It's really diffuse. It kind of goes into the shoulder blades. You can't pinpoint it like someone who has shooting pain on the arm and you could trace it with a pencil. This is very diffuse and overlapping. So here's a nice video we did where we show an area above that the nerve root is healthy, and what we found in our DMX paper is that when you move in certain positions, the facet joint can jam into the vertebra above, narrowing the hole where the nerve root comes out. And here's what that looks like. We just made a nice little cartoon illustration, so to speak, to show how one area has space, not hitting the nerve root, the other one doesn't have space and gets smashed. So now let's say we diagnose facet injury on your digital motion x-ray in our office. What does that mean? short and long term? Well, unfortunately, the facet capsular ligament is innervated by proprioceptive and nociceptive, pain and where your body is in space, and how you move nerves, with projections largely the same spinal level as the facet form from which they originate. Increased peripheral neuronal input to the spinal cord can be sufficient to produce long-lasting central sensitization. That fibromyalgia, central sensitization you heard, because the facet joint got damaged, it can lead to increased pain sensitivity due to the noxious stimuli and the chemicals going into the nerve root and the cord. And that neuronal hyperexcitability in the dorsal horn, that's of the spinal cord, they showed developed within 1 day after a mechanical facet joint injury. So we know that patients that get hurt, not only does their neck hurt, your whole body can get sensitized because those noxious chemicals can be going into and onto the nerve root and even your spinal cord. So how do we see facets on DMX? Well, here's another video where we see the facet joint starting to gap open. And we look for these things. I look for these things. I know what I'm looking for because we're one of the authors. We can determine it, analyze it, measure it. Here's another image of a DMX tear on the DMX that we're looking for, and you'll see where the arrow is. It opens way up. It shouldn't open that far, and then when it comes down, it minimizes into that hole. So how do we know the facet is really injured? We do a DMX. I'm like, hey, there's facet gapping here, and someone's like, I don't think that is. Let me show you the likelihood of injury. In our paper here, as you can see, we looked at what's called facet gapping on the A to P, front to back, on the oblique, and we also looked at symmetrical movement. And what we found was a significant difference. At C5, C6 at one level, 37% of the, almost 38% of the injured population had this. We never saw it in the asymptomatic group. It did not exist. At facet gapping oblique, we found 42% in the injured group and only about 2.5% in the non-injured group. We know what areas are more likely than not to be a problem and more likely than not to be injured. The likelihood of that patient with an abnormal C4, C5 facet gapping finding would be symptomatic was 44.9 times greater than a patient with a normal C4 to C5 facet gapping finding. We published that in our paper. So if we see that, we know that you're 44.9 times more likely to be injured. So if you hear an insurance company, in a car crash or a doc say, I don't think that's a problem, it doesn't matter what they think. We're following what the science shows, and our paper shows that so we can help you get the care that you need so you can stop living in pain. Here's from table 4, this is what we showed. Model 3 down here shows that if you have 2 or more of these findings, you have an 88% likelihood of being injured, and 3 or more, you're at 92% likelihood to be injured. It doesn't matter whether that may not be an injury. Actually, it most likely is. And we published that. That's what our data showed. Now we're going to talk about upper cervical instability. We're going to get into this a little bit. I made other videos on this where we get into this because this is all of it is very detailed, but we're going to talk about the upper cervical instability. There's no discs here. So you can see this wonderful illustration that I took from a radiologist. It's beautiful. And what we're looking at is, are these ligaments and these membranes still intact and holding the regions? So what are some common signs of upper cervical instability? How many of you watching get pain in the back of your head? That could be enough. Like, I have pain. That could be irritation of the upper cervical instability. A lot of times we see dizziness, headaches, not feeling great, pressure in your head, other things like that can also be signs. We're narrowing this due to time. So this is a pretty extreme example of a patient of ours from years ago that was involved in a crash, got evaluated at the hospital, an image. Didn't see this. We did a DMX on him, and this is what happened. And again, this is no fracture. This is soft tissue.
Diagnosed with whiplash, had flexion extension x-rays, and it was missed.
Here's something else that you'll see if you watch C1 at the top here, that top bone. This person in mid-phase, you'll see how the vertebra pops. It floats. Watch. Bloop. Missed because you can't move unless we DMX you. Look, bloop.
Right there, see that?
And that's even some occipital condyle
Just did normal.
irritation or instability. C1 open mouth, we're looking at the accessory and alar ligaments. Show you this here. It's a very hard view to get. I analyze it, stop it when I see the problem, measure it. We're looking at these abnormalities. So here's a great illustration that just shows where we kind of look at the line just for, if you have upper cervical instability, it can look like this. I'll show you here. And we just drew that line in to show you what we're looking at there, okay? So we also have fixed and minimized this pathology with the treatment. Here's a pre and post. This woman had C1 cut in half. That's why you can't see it on here. She also had a fake disc replacement with a significant cervical kyphosis and upper cervical instability. We treated her, we improved her cervical curve, we minimized her upper cervical instability. We've seen a lot of these patients, and that paper is also being published soon. C1 injuries and motor vehicle crashes, you had a trauma. The upper cervical spine ligaments, specifically the alar ligaments, have been associated with whiplash injury in clinical work using range of motion studies like the DMX. In frontal and rear impacts, the highest predicted distractions in the upper cervical spine were for the apical and alar ligaments. We know these ligaments are susceptible to trauma. That was published in Journal of Biomechanics. The AAI, the axial instability, results most commonly from trauma due to injury of the transverse odontoid ligament. The atlanto-occipital joint, the most mobile in the body, is stabilized primarily by ligaments. Therefore, AAI is not uncommon in conditions of lax ligaments, trauma, EDS, other things, but we don't know if you have upper cervical instability unless we really DMX you. And failure to diagnose AAI resides in the difficulty of recognizing rotatory instability on standard X-ray, CT, and MRI. That's why we want to do the DMX to really identify, and they actually did use a DMX in neurosurgical review back in 2020 to identify these pathologies because they're missed. We also published a paper that we got into the Spine Journal talking about upper cervical ligaments. This was back in 2009. We've been talking about these injuries, banging our heads against the wall because no one would listen to us, and finally, patients are being listened to and taken a little more serious of what we've been trying to say here. We'll talk a little bit about anteposition. I'm not going to read this to you, but in car crashes, if your head is turned, that also can increase the likelihood of injury. Now, is upper cervical instability, UCIS, a problem? Well, let's take a look at what we found in our paper. What you can see here, C1, C2 lateral overhang. We found that in 63% of the injured patients and only 32% of the non-injured. The C1, C2 periodontoid space, another measurement we take, we found that in 28% of the injured and only 3.9% of the non-injured. Now what's interesting with this is we never saw both on an asymptomatic individual. So if there was both, there's, according to this data, it's about 100% likelihood of injury. What we found is, again, from our paper, Model 3 results. I mentioned this where you have an 88% likelihood of 2 or more or 92. So what does it all mean? Well, this is what we have published in our paper, okay? These results provide convincing evidence for several conclusions. One, intervertebral stability is a common finding in the symptomatic population of patients with chronic neck pain after whiplash trauma. And two, intervertebral instability is an uncommon finding in the uninjured population. Three, the finding of 2 or more abnormal parameters of intervertebral motion during the DMX examination of the cervical spine is a highly accurate diagnostic test for identifying patients with chronic neck pain after whiplash trauma. So if you're out there suffering and you come to us and we do a DMX and we see you have instability, that is a common finding in injured people. It is uncommon in asymptomatic individual. And the technique and the procedure that we are using, the DMX, is highly accurate. So if somebody says to you, like, I don't care what that test shows, I don't read it, that's not what the science or the data is supporting. You need to find another provider potentially. These findings have importance, again, this is right from our paper, given a number of prior publications demonstrating equivocal or negative MRI results in patients with acute and chronic whiplash, a body of literature that has been transformed into a myth that whiplash is a soft tissue injury that cannot be detected with medical imaging. The repetition of this myth has, in turn, resulted in a number of non-organic explanations of chronic pain complaints after whiplash trauma, including symptom exaggeration, malignant, and secondary gain. How many of you out there that have instability are being told by docs, you're faking, it's not really there? We know these are real problems. We know they are. We've published it, we've proved it, we've helped patients with this, hundreds, thousands of patients with this. But given the high prevalence of ligament injury in the chronic whiplash population and the lack of such findings in the uninjured population, the attribution of complaints to a non-organic source in any chronic whiplash patient without first ruling out pathology via DMX imaging in the cervical spine is unfounded. Come to our office, let us image you, let us get you this report, link it to our paper. You need this information so you can get the appropriate care and treatment. Conclusions we have in our paper is the DMX exam of the cervical spine is a highly accurate test for identifying patients with symptomatic ligamentous instability after whiplash trauma. The imaging modality should be utilized more widely in the clinical investigation of chronic post-whiplash pain. So, let us help you. The conclusion is, if you get a DMX with our office, you are going with the most experienced docs with the DMX. We've had it for a long time, and we're the authors of the largest biomechanical paper of this. An IME, if it's an insurance company, cannot rebut our paper if I do it here. They can if you do it at another center. If we do the DMX, they can't rebut our own paper and our findings. So we can help you with that, especially if it's a car crash. We can explain what's happening, what our paper says, and the insurance company most likely will not be able to hire a doc to go against our paper because they're trying to argue with the author of a paper. And with a DMX at our office, it's going to give an incredibly detailed report. And if you come to us for treatment or an evaluation, an amazing evaluation that we can help you. We've been doing this for 20 years. We've been trying to help patients that maybe just like you have been told you're lying, you're faking, these aren't real injuries. We know that's false, and we publish that information to help you. Let us help you. Come to our office, give us a call. We've done Zoom consults with patients, but certainly getting the DMX at our office is a huge benefit. And if you do not DMX, if a person who's hurt in a crash or damaged or having problems, if you don't have a DMX, you do not know if they have several of these pathologies. And then we don't know what your short and long-term health care is going to be. If you can't rule it out, or if you can't rule it in, you have to rule it out. So thank you for listening. I know this was long. I might try to break this up into certain pieces, but again, let us help you. Getting a DMX at Katz Chiropractic and Rehabilitation Clinic with my wife and I, authors of this paper, very experienced docs, can give you the most detailed report you can get. There's other centers out there that are great. You can give me a call. I know many of them, but there's also centers out there that are just doing really quick, not even giving reports, really don't understand this. Let us help you save a bunch of time and money. Come to our office, give us a call. Let us help you get to someone that can do it accurately if you can't get here. And we know a lot of those centers. So thank you so much. Again, my name is Dr. Evan Katz with my wife, Dr. Shauna Katz in Boulder, Colorado. We look forward to doing everything we can to help. We know both clinically and personally how damaging pain can be and how it can rob your life. And we want to do everything we can to try to fix why you're in pain so you can get a better quality of life. So thanks so much. I hope you found this informative, and I really look forward to hearing from you.